I would like to welcome back Professor Zobair Younossi. He's going to be talking now about decompensated cirrhosis related to hepatitis C and the different aspects of its treatment in terms of why, when, what, and who to treat in these kind of patients.
Thank you very much. So I'm going to start by asking really two questions and addressing sort of the issues. First of all, looking at the evidence, what evidence do we have to support the efficacy of DEAs in hepatitis C patients with decompensated liver disease, and then really address this issue of whom to treat, when to treat, why to treat, and what regimen to choose. So as you just heard with this eloquent lecture by Dr. Colombo, interferon is contraindicated in patients with decompensated liver disease. And I think the best recent answer came from CUPIC that led to side effects, even deaths. So interferon has really no role in patients with especially decompensated liver disease. How about data on interferon-free regimens? This is looking at LDV-SOF in cirrhotic patients who had previously failed previous treatment, and this is from Sirius trial that was published from France. And when you look at this slide, you see two options. If the patient is able to actually take ribavirin, 12 weeks of SOF LDV and ribavirin can give you a 96% sustained virologic response. If you do not have to use ribavirin for whatever reason, side effects or intolerance, then you have to extend the duration to 24 weeks of LDV-SOF, and that will also give you a similar SVR rate of 97%. The other study that I want to point out to you is SOLAR-1. SOLAR-1 had two cohorts. The first cohort, or cohort A, was pre-transplant patients with decompensated cirrhosis, and then you had cohort B, which was post-transplant. The regimens used had interferon, was LDV-SOF with ribavirin either for 12 weeks or 24 weeks. I'm going to only focus on pre-transplant. When you look at this, the data from SOLAR-1 and patients with genotype 1 and 4, and you look across, you see very, very high response rate, being very close to about 90%, 87, 88% sustained virologic response rate, even for child C patients. This is data from SOLAR-2. SOLAR-2 has also patients pre-transplant and post-transplant, but I'm going to basically limit my presentation to the left, which is patients with decompensated cirrhosis that occurred either pre-transplantation or post-transplantation with hepatitis C. Regimen was again ribavirin, SOF and LDV either for 12 weeks or for 24 weeks. And again, when you look at overall response rate, excellent response rate, 95 to 90 to 100% in child B. I have to say that, at least in this study and subsequent studies, when you look at child C patients, the response rate is lower, closer to 50 to 60%. But the rates between genotype 1 and 4 are not very different. One other thing that happens with patients with decompensated liver disease is that their MELD score will improve in some of these patients as you cure the virus or suppress the virus. In a majority of patients, both in child B and C, there was actually improvement of MELD score. There are a few who did not change and a few who actually worsened, but the vast majority improved. This is basically the efficacy of other regimens. So you have SOF LDV, SOF DCV. You also have SOF SIM and also 3D regimen in white. Now I just have to caution you that the 3D regimen was primarily for patients with compensated cirrhosis. But when you look at decompensated patients in the other three regimens, the response rate, at least with SOF LDV and SOF DCV, are over 80%, 82 to 88%. Real-world data was presented from, again, Target. This is the analysis from MELD over 10, And again, you're looking at 3 different regimens. And as you can see here, that the regimens that have ribavirin included had a reasonable response rate, but as you go from the efficacy to effectiveness, you get a slight dip and sustained virologic response rates. This is the early access data from England that was presented by Graham Foster. It's 467 patients with history of decompensated liver disease, and you look at the regimens. This was SOF, LDV, and ribavirin. SOF, LDV, and ribavirin for longer duration, and then you have SOF, DCV, and SOF, DCV, and ribavirin. And as you can see for genotype 1, the response rates are pretty good, at least for SOF, LDV with ribavirin. For genotype 3, when you look at the regimen, as you just heard, genotype 3 cirrhotics with decompensated cirrhosis still remain a challenge without very, very high response rates. Again, about 41% of patients had improvement of their MELD score. About 48% of these patients had no change, significant change in their MELD score. A few patients had sort of no way to return back to normal, and they worsened in terms of their MELD score. There are some upcoming regimens that I want to discuss. One is the Astral 4 data. Now you heard Astral 1, Astral 2, Astral 3. Astral 4 are for patients who are decompensated, and it's with SOF, VEL, and ribavirin, with or without ribavirin in patient with decompensated liver disease. When you look at all patients, the sustained virologic response rate is pretty high, especially if you gave SOF, VEL, plus ribavirin for 12 weeks. You're achieving an SVR rate of 94%. And you look at genotype 1, 3, and 2, 4, and 6, they are similar, the genotype 3 being a little bit lower than the other ones. And I suspect that the regimen that will be approved by the FDA will include ribavirin for 12 weeks of treatment, but that's something that we have to see. Now again, in terms of improvement of MELD score, if you look at MELD scores less than 15, now these are pretty early patients, they're not very advanced, you get actually significant improvement of MELD score, and about over half of these patients improved, and about 1/3 or 27% of these patients worsened. When you go to much advanced patients with MELD scores of more than 15, the vast majority of these patients' MELD scores improved with sustained virologic response. I promised to show you the PRO data. This PRO data has never been presented or published anywhere, so you're first to see it. It is going to hopefully be presented at EASL or DDW. As you can see here, there is a marked improvement in PROs. And remember, these patients are decompensated. So when you actually suppress the virus, not only you get the improvement on quality of life in PROs because there is no longer the virus, but also you have hepatic function improvement, which will add to the improvement of PROs. This is to my right. When you look at the left in terms of SVR, the blue bars suggest SVR 12. So you get already significant improvement of PROs 12 weeks after treatment or after achieving SVR. But if you continue this patient for additional 12 weeks, week 24, you get even more improvement of their PROs. So PROs, this is the first study of decompensated patients and what happens to their PROs with response are tremendously improved after just achieving SVR. Now, of course, when they go under the most dramatic treatment for decompensated liver patient, which is liver transplantation, their quality of life improves dramatically, but at least pre-transplant, that is the only data. Some other regimens, DACLA in SOF in advanced patients. This is from ALI 1. And as you can see, again, this regimen required ribavirin, and response rate was about 83%. So there's a theme that for these regimens, when you treat patients with decompensated liver disease, you probably need addition of ribavirin. This is the Merck regimen in decompensated cirrhosis, the so-called SEA-SALT study. This one did not have ribavirin, and again, the response rate was quite high, of slightly over 90%. So again, another option for these patients. So to summarize the interferon-free regimen for patients with decompensated liver disease, in the near future, the regimens that are mostly going to be with ribavirin for 12 weeks, they're highly inefficacious in patients with cirrhosis, with decompensated cirrhosis. There is some improvement of hepatic function. There is evidence that, at least for VEL and SOF, that we have significant improvement of patient-reported outcome. We have no data on cost, although I reviewed one paper that's going to come out hopefully in liver transplantation, and we are in the middle of actually finishing another paper looking at cost effectiveness of treating these patients pre-transplantation. And I can tell you that overall they are cost effective to be treated prior to transplantation. But the future is really bright for these patients that are very, very difficult to treat historically. So let me get back to the issue of that. Given the data that you just see, which patients should actually be considered for treatment? And in this context, I like to sort of separate patients into three categories. Patients with decompensated liver disease, or could be those patients that have very advanced liver disease, and liver transplantation or treatment will not change the outcome. That's one category of patients. The second category of patients are decompensated patients who are not eligible for whatever reason or don't have access to liver transplantation. And the third category are decompensated patients who are on the transplant list, and the approach is slightly different with all of these patients. Now, coming back to the US guidance data, or US IDSA guidance document, they really advise against treating the first category, patients that the outcome and the prognosis is so bad that you're not going to change anything, so treatment is probably not advised for those patients. How about decompensated patients who are not eligible or don't have access to liver transplantation? They should be considered for treatment, and especially if interferon-free is available. Now, short-term survival of these patients may improve. Their MELD score may fall, their quality of life may actually also improve, but we don't have data on cost effectiveness. Is this a cost effective in terms of prolonging patients' life, and what are that cost that you actually spend on this is worth the society's investment? How about decompensated patients who are on the list? Now, there are a number of sort of controversies over here, but I'll show you at least some of the things that we can sort of look at. The biggest controversy here is that if you treat patients with advanced liver disease and you make their MELD score somewhat better, but not enough to get them off transplant, those patients will be on the lower list on transplantation and may die of complication of cirrhosis without getting liver transplantation. So this is the controversy of when to treat these patients pre-transplantation versus when to treat these patients post-transplantation. This is one algorithm. So if you look at listed patients, and if they're listed for HCC, if they have very advanced liver disease and they have advanced HCC, this is the patient category that you probably don't need to treat, or you should consider at least not to treat. But if you've got child C with liver cancer, and the liver cancer meets the criteria for transplantation in terms of HCC, these patients should be treated prior to liver transplantation. For patients who have earlier liver disease, child A and child B with liver cancer, they should be treated before liver transplantation, because improvement of MELD score is not going to impact their waiting list, at least in the United States, in terms of their status. But if you don't have HCC and you have patients with child B cirrhosis, so they are not going to be transplanted immediately over the next few months because of the waiting time that we have, at least in the United States, you should treat these patients prior to liver transplantation. For those patients who have very advanced liver disease, MELD of 2025, very advanced liver disease, it is probably more advisable to wait, treat these patients post-liver transplantation. The efficacy of these regimens are getting to become about 90% or more in the post-liver transplant setting, and they're pretty safe. That category probably should be treated post-liver transplantation. What regimen to use? So first of all, what regimen not to use? Now, I showed you the target data. In the target data with patients with advanced liver disease, they use semaprevir. This is the problem with going to the community, because people may not follow one of the recommendations that come from toxicity. So when you have patients with child C patients, you cannot use semaprevir. Sofosbuvir, you have to be very careful. because there is actually issue of clearance by the liver, and even the 3D regimen will have problems here for patients with very advanced liver disease. So what is the recommendation by the US guideline? The US guideline suggests that DCV and SOF with low dose of ribavirin, and they suggest 600 milligram of ribavirin, and you go up based on actually tolerance of these patients. That is available for genotype 1, 2, and 3, and 4, and the duration is 12 weeks. For another regimen that is also recommended, at least with genotype 1 and 4, is LDV SOF for 12 weeks, again combined with ribavirin at 600 milligram and going up to what patients can actually tolerate. So this is also a regimen where patients who have failed SOF. So a SOF failure, if they're retreated, they can be retreated with LDV SOF, but they cannot be retreated with DCV SOF. So another regimen that may work is SOF ribavirin. And talking to Dr. Colombo in his unit, when you have experts around, you can get very high sustained virologic response rate in a lot of patients, and that actually for 48 weeks is available for patients with genotype 2 and 3. What is not recommended is on this list: interferon, monotherapy of any of the drugs we have talked about, tenofovir, pulsavir is out of the picture, SIM, and then also 3D regimens are all out of the picture. At least in the United States, they are not recommended. For EASL, for decompensated cirrhotic who are not listed and they don't have a contraindication to ribavirin, they are asked to be treated with ribavirin for 12 weeks, weight-based dose of ribavirin, SOF and ribavirin for 16 to 20 weeks, as you just heard, for genotype 2, SOF LDV for genotype 1, 4, 5, and 6, and SOF DCV for all genotype. Again, this is for 12 weeks. For those patients who have contraindication to ribavirin, then you treat these patients with 24 weeks of treatment with SOF LDV for 1, 4, 5, and 6, SOF DCV for all patients. Interferon is allowed, interferon-based regimens is allowed for child-age cirrhotics, but not for decompensated cirrhotics. For decompensated cirrhotics who are listed for liver transplantation, again, these are the regimens: SOF ribavirin for 16 to 20 weeks for genotype 2, SOF LDV with ribavirin for 12 weeks for 1, 4, 5, and 6, SOF DCV with ribavirin for 12 weeks for all genotypes, and really the data is really limited for some of the very advanced patients. And I understand from my colleagues in Europe that this guideline has to be renewed. The difference between the guideline from EASL and the guidance document from the United States is that the guidance document is a live document. It continuously gets updated, and it is really not a guideline, it's a guidance document, but it's relied on quite heavily by payers. So it is a document that we pay attention to, at least in terms of convincing our payers to provide the medication to our patients. So, in summary, in decompensated patients, interferon-based therapy is really contraindicated. DAs have brought significant opportunity to treat safely and effectively this very, very difficult group of patients, but on this extremely poor prognosis that exists with the patients, all patients with decompensated HCV should at least be considered for treatment. Those who are on the list for liver transplantation and with child C, with child C or a MELD score that is close to 25, you may actually want to wait for those patients to be treated post liver transplantation. And of course, be aware of the side effect of medication, especially SEM and the 3D regimen, and maybe some other regimens as we get more and more experience. And we'll stop here and thank you for your attention.